جاهزة يا دكتورة مروة؟
انا جاهزة براحتك خالص، وانا جاهزة معاك تمام.
تمام. بسم الله. Welcome to our podcast episode today on something interesting. For every pharmacist interested in critical care, general and infectious disease specifically, we will talk today about complicated UTI guidelines and what's new on it. Regarding this topic, we have a special guest speaker, Dr. Marwa Hussein. She is a senior clinical pharmacist at Dar Al Fuad Hospital in Egypt, and she is a board certified pharmacotherapy specialist, board certified critical care pharmacist, and she's also certified in infectious diseases. She's a good pharmacist who is passionate about education and training. So, welcome, Dr. Marwa.
Welcome, Dr. Muhammad. Thank you so much. I'm glad I'm with you today, and thank you for IVPN.
Thank you so much. So, what's new about complicated UTI?
Okay, first of all, the definition of complicated UTI is slightly different this year. The ITSA guideline that was published on July 2025 has slight changes about the definition. Now, uncomplicated UTI is defined as infection that is confined only to the bladder, while complicated UTI is infection beyond the bladder. It may be in males or females and can be categorized into pyelonephritis or maybe catheter-associated or even prostatitis or bacteremic UTI. Taking in consideration, all our talk today will be excluding the prostatitis because these guidelines don't have any updates about prostatitis. It's just complicated UTI.
Yeah, I see. That's good. Then, how to differentiate between complicated and uncomplicated UTI?
Okay, that's good. Uncomplicated UTI, all the symptoms will be just localized to the bladder. As the definition, it's only infection related to the bladder. So symptoms will be localized to the bladder, such as dysuria, urgency, or frequency. While the symptoms of complicated UTI will be extending beyond the bladder, such as fever or flank pain, or even the patient may be hemodynamically unstable.
That's great. Then we always have a problem in selecting the antibiotics, the empirical antibiotics. So how to guide the selection of empirical antibiotics for UTI according to severity, risk factors, and etc.
Okay, the guidelines recommend to have the empirical selection based on four main factors. First of all, the severity balance. That's why for patients with complicated UTI, we are gonna to classify the patients into patients with complicated UTI plus sepsis or septic shock, or the other category, which are patients with complicated UTI but without sepsis. And as we all know, the definition of sepsis is having infection plus organ failure or an increase in SOFA score of 2 points or more. So first of all, we'll classify all the patients according to the severity, if they are having sepsis or septic shock, or they are not having sepsis. The second item is the screening for the risk factor for each patient for risk of multi-drug resistant pathogens. That's why we always recommend to use urinary cultures that are recent urinary cultures. And if for any reason we are having an old urinary culture for the patient, it's important during the empirical antibiotic selection to avoid selecting any antibiotic that was resistant in the previous urinary culture for this patient. And even for patients using fluoroquinolones, it's important to have medication reconciliation from the patient to make sure he was not maintained on any agent of the fluoroquinolones during the past 12 months. The third item is the patient-specific consideration, which is such as allergies, such as drug-drug interactions, such as side effects or contraindication. That's the individualized patient care. And finally, it's about the antibiogram. But to use the antibiogram, it should be local antibiogram, which means the data presented in our antibiogram is related to our hospital, not any other neighbor hospital. And it should be recent. which means that the data we are using are presenting the sensitivity data of the previous 12 months. The recent guidelines recommend to use the empirical choice of antibiotic based on the antibiogram for the patient with complicated UTI having sepsis or septic shock, while there is no any recommendations regarding the patients whom are having complicated UTI without sepsis or without septic shock. And then finally, how to practical-wise use the data in our antibiogram, which is local, which is recent, to choose the empirical antibiotic. If we are having a patient with complicated UTI and having septic shock, we are gonna to select an antibiotic with 90% or more sensitivity for the suspected microorganism. While if you are having a patient with complicated UTI with sepsis but without shock, so we are gonna to select one of the agents that have at least 80% sensitivity for the suspected microorganism. So whenever we are choosing an empirical antibiotic for any patient, we'll be guided with the 4 main items: severity of illness, patient risk factor for MDR, and any patient-specific consideration, and finally, our antibiogram.
Okay, that was great and specific to the point, either the severity of illness, risk factors, specific considerations, and antibiogram. That was great. Then we have another question. Are there any recommendations for empirical antibiotics treatment for complicated UTI?
Yes, sure. As we mentioned minutes before, first of all, we are gonna to classify the patients according to the severity. So we will have 2 major categories: patients with complicated UTI whom are having sepsis or septic shock, and the other category is patients whom are having complicated UTI but without sepsis or without septic shock. Okay, first of all, patients whom are having sepsis or septic shock, their treatment will be a better broader spectrum. We can use 3rd-generation cephalosporins such as ceftriaxone or ceftazidime or cefotaxime. We can use 4th-generation cephalosporins such as IVPN, and we can use fluoroquinolones, but taking in consideration that the only fluoroquinolones that are approved to be used in urinary tract infection are ciprofloxacin and levofloxacin. And we can use piperacillin tazobactam. And finally, which is just to be used for patients with sepsis or septic shock, are the carbapenems, either ertapenem, imipenem, or doripenem, or emipenem. The other category are the patients who are having complicated UTI but without sepsis. It will be the same management, but excluding the carbapenems. So for both categories, we are going to use either 3rd-generation cephalosporin, 4th-generation cephalosporin, piperacillin tazobactam, or fluoroquinolones, either ciprofloxacin or levofloxacin. And carbapenems are only to be used for patients with complicated UTI and sepsis or septic shock. All this if the patient is not having risk factor for MDR. As we mentioned before, we will screen all the patients for risk factors for MDR. Whenever we are having risk factor for MDR, we can use novel beta-lactams such as ceftazidime tazobactam or ceftazidime avibactam, or even meropenem vaborbactam, or cefdiericol or aminoglycosides. But for sure, we should be careful during the use of the novel antibiotics to avoid resistance. Take care. Some patients, we need to start with oral treatment. So if you are targeting to start immediately with oral treatment without being on IV treatment, you can use fluoroquinolones or try methopram. And finally, the guidelines recommend avoid nitrofurantoin or oral fosfomycin. Although maybe practical-wise, they are widely used for UTI, but the guidelines recommend to avoid their use in the complicated urinary tract infection, as they don't achieve adequate levels in renal parenchyma or even the blood.
Okay, that was great, very great about empirical antibiotic treatment recommendations. Thank you for these variable recommendations. In case we shifted from the empirical use to the definitive therapy, when a culture is revealed and its result shows some choices, more than one choice. So, about the selection of definitive antibiotic therapy for UTI, what do you think?
Okay. First of all, we start empirical, which is broad spectrum, as we mentioned. After that, whenever we are having urinary culture result, we should be going for the definitive therapy, which will be narrower spectrum, and our selection will be based on many factors, such as patient-specific factors, such as allergies, drug interactions, side effects, or contraindication, and we should select an agent with good distribution to the urinary tract infection. And this is much more better than continuing on the same empirical antibiotic therapy to avoid resistance.
Well, that's great. About the transition of IV to oral antibiotics, as you know, we need to shift from IV to oral antibiotics, whatever or whenever we can, as soon as possible. So, is there any recommendations about this transition?
That's perfect. We are always aiming to shift from IV to oral in order to decrease catheter-related infections and in order to decrease the cost on the patient. So whenever our patient is clinically improving and tolerating to take oral medications, and the most important thing is having an oral available option, which will be effective. At this level, we can shift from being on IV antibiotic to oral antibiotic. But kindly take care that this theory doesn't apply to all patients, which means if you are having a patient whom immunocompromised or having septic shock or severely renally impaired, this theory will not apply to them. So these patients will be individualized criteria according to the patient response.
Okay, what is the recommended duration for these treatments?
Okay, the guidelines recommend shorter duration as we can, which is if the patient is clinically improving, if the patient is on fluoroquinolones, it's recommended to shorter the duration to 5 days rather than being on longer therapy. And for patients on non-fluoroquinolones, the duration will be 7 days. But take care, whenever you are calculating the duration, the first day we will calculate is the first day on being on effective antibiotic therapy, which means if you have starting an empirical antibiotic therapy for patients with complicated UTI, and then therapeutic failure occurred and you have shifted to another antibiotic. So you will start calculating the duration of antibiotics from the first day on being on the effective antibiotic therapy, 5 days if it's fluoroquinolone, or 7 days if it's non-fluoroquinolones. But studies for the duration was excluding patients whom are still having urinary catheter, patients whom source control is not done, patients with severe sepsis or immune compromised, or patients with chronic prostatitis. So kindly take care of the risk factors of the patient before deciding the duration of the empirical treatment or the definitive treatment.
That's great, Dr. Marwa. So, you told us about the definition, the new definition of complicated UTI and the differentiation between complicated and uncomplicated UTI. Then you guided us for the selection of the antibiotics, either empirically or definitive therapy as a definitive therapy. Then you gave us recommendations about transition of the antibiotics from IV form to oral form and declared what's important about duration of treatment. So really, this was very useful insight. Thank you so much, Dr. Marwa. We are honored having you today in our episode of this podcast, and we are honored to have you in our critical care IVPN critical care list, sir. So thank you so much.
Thank you, Dr. Muhammad. It's all my honor. Thank you, and thank you for IVPN.
Thank you.
Thank you.